Hi, my name is Poonam Velagapudi, and I'm an interventional and structural cardiologist at the University of Nebraska in Omaha, Nebraska. I participated in a session yesterday on left main bifurcation PCI with imaging, and I'm going to summarize our discussion points from the meeting. So the first question when it comes to left main bifurcation PCI is the importance of imaging use. I think we all agreed as a panel and as a group that the use of intracoronary imaging is a must, both for diagnosis as well as optimization of the stents in left main PCI. Oftentimes we think about a lesion as Medina 0, 1, 0, but when we image, we see it may be involving both ostia of the LAD and the circ, and it may be a 0, 1, 1 lesion. So not only that, we need the imaging to size our stents as well as optimize it post stent. There's a lot of observational data that supports the importance of intracoronary imaging in left main PCI, including mortality benefit, and there's a lot of ongoing randomized trials, the optimal trial, the infinite trial, and the DK Crush 8 trials, all comparing angiography versus IVUS-guided PCI in left main lesions, in PCI of left main disease. The second important thing that we discussed was the technique of the PCI. So we know there's data from EBC2 and EBC main supporting provisional stenting as opposed to upfront two-stent strategy. We also have data from the DK Crush 5 trial where the upfront DK Crush strategy was better than provisional stenting in terms of outcomes. But as a group, I think we all, there were a lot of cases presented, trifurcation as well as bifurcation disease, and again, intracoronary imaging was used in these cases, and the operators decided on a stent strategy based on findings of the intracoronary imaging. And I think provisional is a good option to begin with. And if the side branch was affected in terms of reduced flow, or if there was a dissection or something else that needed a stent, then a stent could be placed. Now, the third important thing that is really important in left main PCI is to use the heart team approach. Any patient who has left main disease must be discussed as a heart team to decide which would be the best method of treatment. We know that PCI is a class 1 according to European guidelines in patients with low syntax score, class 2 indication for those with intermediate syntax score, and a class 3 in those with high syntax score. So we follow guidelines and we determine which patient is best suited by PCI. And then the final discussion was whether or not to use mechanical circulatory support. And I think in a left main PCI where the EF is normal and the RCA is okay, probably mechanical support may not be essential, but in those cases where the RCA is a CTO or the EF is depressed, mechanical support would be helpful during the PCI. So this was the summary from our left main bifurcation session with PCI session with imaging, and I hope I was able to summarize it for all of you to understand this. So thank you very much for having me. I'm really excited to be at CSI NIC meeting this year. Thank you.